So we decided to look at resilience in our patients because we know that HS has a large negative impact on these patients. Generally, they have lower overall health-related quality of life. Evidence also shows higher rates of depression. For this study, we defined resilience as the ability to successfully adapt to stress and adversity. We also know that resilience plays a role in mitigating stress, the impact that stress has on depression through the literature. Lastly, resilience is a learned behavior, and it's important to note that because we can alter that through therapeutic and clinical interventions. For this study, we conducted a multi-site cross-sectional survey. We collected data from 2 different sites at Penn State Hershey Medical Center and Zeeland University Hospital in Denmark. We used 4 questionnaires, the socio-demographic and clinical characteristics. We used the Brief Resilience Coping Scale, the Hospital Anxiety and Depression Scale, and the Dermatology Life Quality Index. All had pretty high internal consistency when we calculated that at the end. Mean age was pretty consistent with other studies that we've seen, 41 years old. Depression symptoms were pretty moderate. On a scale of 0 to 14, we had an average score of 8. Resilience was also pretty moderate. On a scale of 4 to 20, we had an average of 14.5. For the DLQI, we actually reverse coded this, so lower scores indicated lower quality of life, and the mean score for that was actually a 10 out of a scale of 0 to 30. The majority of our patients were female, and a large portion of our patients also did have at least some education. You can see the percentages for some education, bachelor's and graduate. We actually did have a pretty well-educated population. For the model, we found that resilience does moderate the association between depression and health-related quality of life. We created a multiple linear regression model. The reduced model had depression, resilience, disease severity, and gender. Actually, I think there's a mistake there. It did not include gender. The adjusted R-squared for that was 0.55, and the Akaike information criterion was 957. When we added the interaction term of resilience and depression, the adjusted R-squared did increase and the AIC did decrease, indicating that the interaction term is significant and the expanded model was actually a better fit for the data. So we know that that interaction between resilience and depression is significant. Just to kind of give you a visual on what this means, on the bottom scale, we do have depression symptoms. So as depression increases for these patients, you see quality of life goes down pretty drastically. For those on the black line, those are those with low resilience. For those with higher resilience, indicated by the red line, that slope is a good bit lower. So higher resilience helps to mitigate that effect that depression has on quality of life. And this did hold true for a good portion of the participants. For anybody with the highest levels of resilience, which was a score of 19 or 20, this did not hold true. But for everybody else, which was a vast majority of the population, we did see that this was significant. Limitations for this study. The survey results were collected through a self-administered, self-reported survey. We did work with institutions and patients were identified through the medical records, but it was done through an online survey and they did have to self-report disease severity. So the activity was self-reported. The sample size was also limited to only those who offered complete responses to all questions asked. So conclusions for this, we know that health-related quality of life for patients with HS is effectively modeled by disease severity, depression, and that this association is moderated by resilience. So depression, will have a negative impact on quality of life, but resilience can help lessen that impact. And patient-related rated disease severity did worsen independently of the depression score. We also concluded that higher levels of resilience moderated depression scores with improvement in health-reported quality of life. This effect was, again, not significant for those with the highest levels of resilience. Resilience is also, as I mentioned, a learned behavior. So with higher levels of education and therapeutic and clinical interventions, we can help teach patients to cope with this disease a little bit better and to help manage that stress that they feel. We would like to thank Solveig Esmond and Gregor Jemick, who were our partners in Denmark. And that's it. So any questions?